about wastewater surveillance first, because our special presenter has to leave a few minutes in, and then our normal epi and updates. I made a presentation about pets and healthcare that was super fun to make. And then Barb, one of the infection preventionists on our team, is going to talk about resident safety and infection prevention and control. As always, feel free to ask questions throughout. So I'm going to turn it over to Dorothy to talk about wastewater surveillance.
Hi, everybody. Can everybody hear me okay?
Yep, we can hear you.
Okay, great. I am Dorothy Folks. I am the Manager of Quality Assurance Molecular Surveillance for our laboratory-based surveillance program with CDPH. And our wastewater surveillance is one of our surveillance projects/programs. So this is just a quick and dirty overview of what is wastewater surveillance. So wastewater surveillance aims to act as a complementary surveillance tool to augment traditional syndromic surveillance and act as a possible early warning system for disease outbreaks for pathogens of public health concern. So what that really means is a population level surveillance tool that we use to look for trends in real time. We are looking to see how a illness or disease is moving through a community or a facility. Next slide, please. So a few of our wastewater surveillance partners are academic laboratory partners, our University of Illinois at Chicago, and Discovery Partners Institute, which is a part of the University of Illinois system. But it takes a team to pull this off. So we do work with several other partners, as you see listed below. Next slide, please. And this is just some quick team organization, just so you can see how many people are working behind the velvet rope or behind the velvet curtain, as they say, to produce that wastewater surveillance data for us. Next slide, please. So this is just an overview. Currently, we are monitoring SARS-CoV-2, influenzas A and B, RSV, Candida auris, Mpox, previously polio, C. auris, and any other pathogens in wastewater that are of public health concern. This potentially captures changes in disease trends or emergence that's not detected through routine clinical testing. If you think of like a Swiss cheese model, we are hoping to capture what may be missed through clinical patients interfacing with healthcare system. This involves a lot of collaboration and involvement of multiple agencies and partners. Oftentimes, we may be capturing movement of disease through community or facility, and it hasn't yet reached the level of clinical awareness or confirmed cases. Next slide, please. So this is just a brief surveillance workflow. Somebody has to go out there and get the sample. It's dirty work, but it's important work. So the sample is collected. That sample is taken to the UIC academic laboratory where it is concentrated and extracted, and we run digital PCR, we do quantification, we do sequencing for SARS-CoV-2 at Argonne National Laboratory, and we do some data visualizations with Northwestern University modeling analytics reporting. And then that data is shared with IDPH, internal sister programs within CDPH, external partners, and CDC. Next slide, please. So this is just a map to help you understand where are we sampling. So we've got 8 City of Chicago sewer sheds in blue. If you look at the map that is on your right, 6 of them are Chicago Healthy Equity Zones and 2 pumping stations and 2 facility. Actually, I'm sorry, this is not accurate. It's 1 facility right now, CCJ. We have temporarily suspended sampling at Misericordia. The timeline is 1 to 2 times per week per site. So you can see by the map that is on the left, this is where the water reclamation plants are, how large population is being served. And then when you look at the Chicago Healthy Equity Zone sites, these sites were established during COVID. And these were the sites that were identified to make sure that we were gathering data equitably and equally across the city of Chicago, across communities and populations, if that makes sense. Next slide, please. Okay, and our 3 pumping stations. So we have kind of a 3-tiered system. We have very localized sampling at the Chicago Healthy Equity Zone sites, right? So we get community level data. But then there's also sampling that happens at the wastewater reclamation plants, and that's a lot of people. That's a large population. But we wanted to capture something with medium sewer shed, right? So that's what the pumping stations are. We have 3 of them. There's the North Branch site, Racine Avenue, as you see in yellow on the map on your right, and 125th Street, which is, I guess we're going to call that orange. Um, those pumping stations were important to us because we wanted to capture something in between those large wastewater treatment plants and those very strategic localized community sites. Next slide, please. So what's important to understand is what wastewater surveillance can tell you and what it cannot tell you. So what it can tell you, it supplements other surveillance methods during outbreaks, either at the community level or facility level. Um, it is an independent surveillance method, and we do interact with case-based reporting. So we will find clinically confirmed cases and see where those cases are in which sewer shed. That helps us to tell which community might be experiencing an increase or spread. We do post this wastewater data nationally. We do use it to support improvement in other areas. And we're establishing community spread thresholds with gene copies and specific concentrations. Every pathogen is a little different. So sometimes we can do concentration and quantification levels. SARS-CoV-2 is a great example of that. What we cannot do. So during periods of low community transmission, they may produce non-detects, and that's because the concentration levels have not reached a detectable level. So we can never say, oh, it's not present. What we can say is it has not reached a level that we can detect. We can never say with certainty that a pathogen is absent, if that makes sense. We cannot really use this as an early indicator. What we can do is use it to detect trends, increase, decrease, spread, or incidence. We are not able to accurately quantify community spread, right? This is population level. So I cannot tell you by a wastewater sample how many individuals are sick. That's not something it can do. And gene copies do not equal a clinical confirmed case. Next slide. Or this might have been my last slide, actually.
I
Yep,
think it is.
like that was the last slide. Okay.
Thank you.
Questions,
Yeah,
comments,
does
cares, concerns?
anyone have any questions about wastewater surveillance? Now's your time.
Yes, CCJ is Cook County Jail. I'm so sorry. I
Oh,
said that with the assumption that people knew what I was talking about.
okay. Javante, you have a question. Go for it.
Is how like user friendly would it be to like see, for example, I know that you said that it's not a good indication for early detection, but what about in situations like if I wanted to see uh to know like what of the results for like Canada or it's right now, like where can I find that stuff? Is this information available to the public or is it just, internally right now?
So that's a great question. Some of our information is available to the public, and some of it is internal with other sister programs or to external stakeholders. Our MPOX wastewater dashboard, and I am looking for the link. I'm so sorry. One second, y'all. Here we go. I think I got it. Let me copy this. I'm gonna drop it in the chat so that you all can see like what does that data look like when we get that data? How do we analyze it? How do we create the visualizations? So some of our data is publicly available, like SARS-CoV-2. Some of our data is internal. We're only sharing it with the partners who are asking us to do that surveillance for them. For example, CORIS. Does that answer that question?
Yes, so COVID is the only one that's available publicly, and the other diseases right now are still like just being shared amongst your partners.
Right. Those are
Uh,
just like internal dashboards.
Okay. Okay. Got it. Thank you.
I think
Hi,
Christy has a
everyone.
question.
Yeah, hi. This is Christy Zielinski. I'm also on the healthcare settings team with Liz and was involved in asking Dorothy to present this to everybody. And Javante, thank you for that question because it kind of leads into why we asked Dorothy to come on in the first place. As you know, we are starting to see more XDROs that our team has talked to you guys a lot about in skilled nursing facilities. And this is not a population that we normally see, specifically Canada Oris, colonized in at a high level. But because we are starting to see it more in our skilled nursing facilities, we want to look at using wastewater surveillance as uh, a less labor intensive way to see if more of the skilled nursing facilities within the city of Chicago are affected by CRS colonization or other XDROs. So we may be reaching out to a few facilities to ask if they would like to partner with our wastewater surveillance program. So that is how we wanted to give you guys this kind of overview of what our program looks like. And then we can start asking folks if they're interested in partnering with us. And if that is the case, then please reach out to Liz or myself or anybody on the team, and we can talk more about what that entails. So thank you.
Awesome. Thanks. Anyone else have any questions?
I also dropped the link to the COVID wastewater dashboard so you all can see what that data looks like. And please, if you think of any questions or there's anything you want to chat more about, because it's interesting to you, do not hesitate to reach out.
Thank you so much. Appreciate it. That was a very interesting presentation. I don't think we've had anyone talk about wastewater surveillance on this call before. Okay, now we move to the boring stuff, COVID. So this slide is just showing that everything is still Omicron. There's different kind of variants coming in and out, but it's all Omicron still. This slide is showing the respiratory virus surveillance data from the week ending June 15th as compared to the entire respiratory season. So as you can see, flu and RSV, nothing much is happening there. But overall, since the beginning of the 2023-2024 respiratory season, 6.7% of specimens tested were positive for COVID. And right now it's 4.7. So it's not at like the average yet, but it's still pretty high for this time of year. And we have been seeing some larger outbreaks. I think we have one facility with 40 resident and staff cases over the past couple of weeks. So definitely still be on the lookout for COVID. Hopefully you guys have enough tests available. If not, try to talk to your corporate offices to make sure you have enough on hand because as you know, these outbreaks can spread very quickly. And then this is just the map of seasonal trends. In terms of reporting, I just wanted to give a reminder that we've moved to that new system. I think we've talked to each of your facilities at this point explaining what that new system is, and we've gotten reports from a lot of you, so thank you. So the main change to discuss other than the new link is that we are now only asking you to report outbreaks, and the way we are defining outbreaks is 2 or more cases within 14 days. Only those are reportable for COVID at this point. IDPH definitions are pretty similar. They have like a couple little caveats, but for us, if you've had 2 cases within 14 days, you need to report. If you do not have 2 cases within 14 days, you only have 1 case, you don't need to report. So just giving some examples, let's say your first case was June 1st, and then you had another case June 23rd and no cases in between, you do not need to report either of those cases to us because there have been more than 14 days between those cases. But if you had a case on June 1st and then another on June 10th, then you would have to report because there were 2 cases within 14 days. So hopefully that makes sense. If not, let me know. And then I wanted to touch base about our ICAR visits. So those are infection control assessment and response visits. It's just our normal site visits. We have hit every single one of your facilities at least once since the beginning of COVID. We are doing both prevention-based visits where if we haven't been there in a while, or you have a totally new team, we'll come out and do these ICARs. Or if response-based visits, so let's say you have an invasive group A strep outbreak or a Candida auris outbreak, now we're trying to be better about coming out pretty soon after that to help you shore up your infection prevention and control practices that might be contributing to that outbreak. So as hopefully most of you know, except for maybe some of the new people, we do schedule that visit with you in advance. We'll say, here's when we're hoping to come out. Does that work for you? So it's not like we do like random pop in like some of the surveyors would do. And again, we're not surveyors. So we work with you to have a time available. We send you the information that we need from you in advance. We have the certain people who we'd like to be there, ideally the administrator, one of the clinical leadership, so the DON, ADON, or IP, or preferably all of them. And then we also need to talk to your EVS manager at some point. So because we tell you the time in advance and schedule that with you, it's really important for us that you're available at that time. There are a lot of times where the team gets thrown into a room, probably because everyone's scrambling on the floors, making sure everything's okay. But I've advised them to do is if they're left waiting for more than 15 minutes, then I tell them to go to the floors and start walking the floors and do their observations. And then usually someone just pops out of the woodwork. So again, please be respectful of their time. We're respectful of your time. Try to keep it within that 2-hour time frame we schedule. And if they are left waiting and no one's available, they'll just start walking the floors. Again, we're not regulatory. We're not surveyors. This is not going to IDPH. There are no fines or citations. The purpose of this is for us to complement our phone calls with you and get to know you better and for us to assess in person and then be able to give you the recommendations. And it's actually super helpful because we look at some of the stuff that a surveyor would also look at. So if you can get us in first, we can find something, you can fix it, and then when you have your actual survey, you won't get cited on that. So all of our visits across the board, regardless of whether they're outbreak or just prevention focused, they look at your policies, how you guys do auditing for things like hand hygiene, things like hand hygiene expectations, when are people expected to clean their hands, your transmission-based precautions, enhanced barrier precautions procedures, and then environmental cleaning and disinfection. There are some situations, so there's certain modules that CDC has. Those are 4 of them that we do across the board on every visit. However, if let's say there's an outbreak of invasive group A strep and we see that a lot of those cases did receive wound care, for example, then we might do one of those additional modules on wound care to see if we can see any deficiencies that might be contributing to that spread. And then after the visit, you get a full copy of our ICAR tool, which is a super dry CDC tool like checklist. And then we also write up a list of our key recommendations. And then our PHAs, they're public health administrators, they're the ones who go on site and audit. So they'll watch staff to see if they perform hand hygiene, and they'll use that glow germ and mark some surfaces and then come back a few days later to see if it's cleaned. So they'll prepare a summary report of that you're definitely welcome and encouraged to use with your leadership and at your QA meetings and things like that. And then they also will go around and check your PPE bins and be able to say, hey, the bin outside this room is missing gloves. So things like that. And again, we've hit everyone at least once. We're trying to do as much as we can. But if you want us to come on site, we're happy to do so. Just either put it in the chat or you can email me and we're happy to come out. And I'm going to try to go on a couple more as well because I haven't seen some of you in a few years. Okay. Oh, so Francis, so unfortunately, fortunately, the guidance that you guys, so like the assisted living and supportive living facilities now can follow what is the community guidance, which is much more, it's less restrictive now and less prescriptive. But for facilities, the nursing homes, like the skilled nursing facilities, you technically are still under the IDPH healthcare guidance document for COVID. So even though the rest of the world is kind of moved on. CDC has not changed the recommendations for nursing homes or hospitals. So one case would not necessitate outbreak testing, but you would need to test those close contacts. And then if any of those people test positive, then you have to expand the testing. So if I'm in room 302 and I test positive, then you should test my roommate, anyone I hang out with at group activities or, that sit with me at the dining table, any staff that might have been around me with no mask on. If all of those people are negative, you test them in like a series. And if they're all negative, you can stop there. If, let's say, 2 people at the table I sit with for dining test positive, then you have to expand. And no, the ICAR is not required in terms of prevention-based ICARs. So like if we're like, hey, we haven't been there in a while, or your team is new and we'd want to come out, We don't usually have people say no. Like technically, you don't have to, but again, it's just meant to help you. But what is mandatory is, let's say there's an outbreak response. So in, oh, I'm getting an echo if people can. Okay, sorry. If there's an outbreak response, we have a great deal of powers outlined in the administrative code, and basically can do what we need to do to help control that outbreak. So in that situation, like let's say you're having a massive C. outbreak, and you're like, no, I don't want you to come in. We're going to be like, too bad, we're coming. Let's work on a time. So again, we have been to all of your facilities so far. Hopefully, you guys realize we're not like snitching on you to other powers that be. We're there just to help you. So I hope that answers your question. If it doesn't, let me know. Okay. Now I'm putting a disclaimer. No CDPH staff are allowed to answer this question because I already told you the answer. But for the rest of you that are from facilities, we're moving into our pet presentation. So I'm going to leave this up for a minute. Which of the following are allowed to be service animals in your facility or in any situation? And there might be more than one answer. I'll leave it here for a second. Remember, no CDPHers can answer. I'm going to sit here awkwardly until someone puts an answer in the chat. Mark, I'm calling on you. Okay. Thank you for the 2 people who answered, including Mark. Oh, 3 people. Awesome. Okay, so it looks like the answer that people are putting is dogs. Let's find out. So wait, what did Mark put as the other one? Oh, look at you. Okay. So yes, usually a service animal is a dog that's trained to do work or perform tasks for the benefit of an individual with a disability. However, and I'm trying to figure out where this came from because I feel like there was some lawsuit or something that made this be, but in certain circumstances, mini horses can be service animals. But that's it. A cat is not a service animal. A pig is not a service animal. It is a dog, and in rare circumstances, a miniature horse. Have any of you had mini horses in your facility as a service animal? I'm very curious. Throw that in the chat. Um, and then the tasks that they can do, like guiding people who are blind, is a lot of people have seen service animals do that, helping people who are deaf be alerted, pulling a wheelchair, helping people remember to take their medicine, help predict a yes, miniature horse. Helping people remember to take, yeah, medications or alerting someone if they're about to have a seizure. And just as a disclaimer, so I watched a presentation at APIC, which is the Association for Professionals in Infection Control. I think it's a conference about pets, and I was like, I'm going to do a presentation about pets. Oh, there has been mini ponies at the VA. Interesting. Okay. So here's a little bit. Again, I went down the rabbit hole. Well, Javante, you can have a service animal in here. We should find out for CDPH. Anyways, I went down a rabbit hole because this is fascinating to me about the mini horses. So just so you know, they're smaller horses. They range in height from about 2 feet to 3 feet. They weigh between 70 to 100 pounds, which I actually thought was lower. I would think it would be higher, the weight. They can be helpful for people with mobility issues. They can help stabilize people. And there are certain circumstances where a mini horse can enter a facility. So they have to be housebroken. So if your mini horse is peeing all over the place, you can be like, get out of my facility. They have to be under the owner's control. They can't just be out and about galloping around. You have to be able to accommodate the horse's size, weight, and type. I feel like all of you probably can do that. And then the presence of the horse should not compromise the safety requirements or the operation for other people in the facility. But yeah, in most situations, as long as it's not peeing everywhere, you have to let them in. So this is very important for you guys, and you should put this in your respective policies. So as per the ADA, if it's not clear what service the animal provides, you are only allowed to ask 2 questions. You cannot ask any other questions. The 2 questions are, is the service animal required because of a disability? And what work or task has the service animal been trained to perform? You cannot ask them, what disability do you have? Be like, show me some proof that it's a service animal, show me that it's trained, or like, oh, you said it can, alert you to a seizure, prove it. None of that. You can only ask those 2 questions. Again, these slides are available, so they'll be sent out to you. They'll be posted on your website, or our website. So again, feel free to go look at them again and steal some of this for your policy language. Again, service animals, they must always be under control of the owner. They should be harnessed or leashed unless they have to not be harnessed or leashed to be able to perform the tasks they need to do. And in that situation, they should be able to for both residents and staff. Basically, anyone who has a disability, if they have a service animal that performs some task, they should be allowed to have that. But sorry, I'm like answering the chat as I'm talking. Um, so if they can't be harnessed or leashed, there has to be some other method by which the owner can control them. So like maybe a voice or a signal or something like that. They can only, and I'm going to kind of go back to dogs because most of it is dogs, most service animals. So they can only be asked to remove the dogs from the premises, including your places, if the dog's out of control and the handler doesn't take effective action to control it, or the dog is not housebroken. And then this is also very important. Allergies or fear of dogs are not valid reasons to exclude a service animal from the premises. So if you have a resident that wants to bring in a service animal and they are helping them with some task, and then, the CNA dealing with that resident is allergic to dogs, you can't be like, oh, sorry, this resident can't have the dog if it's a service animal specifically. So again, service animals are only certain types of animals doing certain tasks. And we'll go over other types of animals as well. Okay, so where are they allowed in nursing homes? They must be allowed in any situation or any place where a resident or visitor would be allowed to go. Staff, I didn't look into it too much. But your lobby visitor is allowed to be in dining area, the residence room. So all of those places, if the owner or like the person that is using the service animal is there, then the dog or miniature horse should be allowed to be there as well. But it does not include places where visitors or residents would not be allowed to go. So you shouldn't be, if the resident is sitting in the dining room, the dog should not be in the kitchen. But if it's a place where the resident that is using the service animal or the visitor that is using the service animal is allowed to be, then that dog should be allowed there as well. So that's service animals. Again, those are like for one person doing a specific task due to a disability. But there's other things, as I think a lot of you guys have in your facilities, which are either animal assisted therapy or animal assisted activities. So animal assisted therapy is usually like, again, one animal, which does not have to be a dog, to a single person with specific interventions. So goal-directed interventions that incorporates an animal into the treatment process. It's meant to improve things like, cognitive functioning or social or emotional functioning. And then a therapist is the one that guides that activities, and that's documented and charted and things like that. So that's what animal assisted therapy is. Then there's animal assisted activities, which again, I think most of you, or maybe not all of you, but a lot of you have. So that's when like the dogs come and like everyone pets them, or apparently ducks come in as per this picture. So there's not really a specific individualized goal for the visits. It's more just like socializing the residents, having them have that, contact with animals. So again, this is what a lot of you guys have in your facilities. And then in that situation, again, it's usually like a group situation. They can visit animals in either a common central location or in their rooms if they're bedbound. And this, again, is not restricted to certain types of animals. As you can see in the picture, there is a duck. So again, the AAA, the animal assisted activities, is kind of an umbrella, and then the animal assisted, I think that's what it's called, therapy, is a subset of that. That's again more goal directed. So these are what should happen for any animals that are entering your facility. Again, this is kind of excluding pets, but these animals are usually considered pets in general, or in the same category as pet, not considered a service animal. They have to be in good health. They need to be up to date with all their recommended immunizations, including rabies, and you guys should have that documentation on file. So it's fine for if you're bringing in a dog for pet therapy with the residents, you can ask for the recommended immunization, or like having the immunization copy or record, and then double checking. Just in general about rabies, most dogs are vaccinated against rabies. And generally speaking, for rabies in general, what you look for in rabies, which again has not really been reported that much, you look for whether it's can even have rabies. Like certain small animals they can't even have rabies. I think like smaller than a gerbil would not have rabies. And then is the bite provoked or unprovoked? And what they would look at as provoked is not just like, oh, you're roughhousing with the dog. If you're touching the dog's food, if you're feeding the dog, grabbing the dog's food, anything like that, and the dog bites you, that would be considered provoked. If you're petting or up in the dog space, that's provoked. So it's really an unprovoked bite would be like you're sitting there minding your own business and this dog comes out of nowhere and bites you. And again, you shouldn't really be letting dogs in for therapy without the immunization record. Most dogs are vaccinated against rabies, so rabies would not be like a huge concern for me. Oh, I see some questions. Do I have a list of AAT or AAA animals who service the Chicago area? I don't, but there are websites with that. And a lot of them like I would recommend you going through like a reputable agency, and then they might do all of this stuff for you, making sure that they have immunizations. But I did Google some organizations. I can try to find one. I'll try to find one when Barb's presenting, because I did find a good website that has a lot of different like companies that work with that bring in these animals. So I'll send that. Oh, another totally unrelated point from a visit I did recently with Nazreen is we went to, that you might think is funny, we went to an assisted, maybe a supportive living facility. And I know a lot of you have those little aviaries, and they had an aviary. And during COVID, they worked with, or before COVID, they worked with the service that would come and take the birds every once in a while, because the birds would have babies, and they didn't want inbreeding of the babies, and they didn't want overpopulation of their little aviary. So the service would come in and take the birds away, like the baby birds, and leave the adult birds. But apparently that service went out of business during COVID. So then they were just left with this huge amount of birds that they had to deal with. So they put the aviary out of commission for a little bit and are now bringing it back slowly. But I don't know if that happened to some of the others of you that have aviaries, but I didn't even think about that. Anyways, back to the actual presentation. They need to be up to date with their prophylactic medications like heartworm. They should be screened regularly for enteric parasites. They need to not have fleas or ticks on them. They should really be clean and well groomed. Ideally, they should be bathed within the 24 hours prior to their visits. And then they should not have wounds or broken skin. And Jamonte's putting some good facts about the cost of miniature horses in the chat. And then above and beyond the pet, the handler also should be in good health. So even if the pet is super healthy, if your handler's coming in with a fever and coughing and sneezing and things like that, then that is of concern. And then there's a lot of benefits for pets in healthcare. I've put, so I'm not going to read through everything, but there's source of where I got this from is at the bottom, but they have shown that it really improves, it can improve people eating, it can improve social behavior, it can decrease agitation and anxiety. This is interesting. One of the studies showed subjects exposed to a fish tank had greater weight gain. So it really just having pets around helps make it more of a home-like environment, helps increase socialization. So that's great, but there are some risks as well. Oh, Shane, yes. Oh, Marie, what's up? Or Marie, I see your hands up. If you can come off mute. If not, we can come back to you. Okay, I'm going to continue then. So in addition to the benefits, there are also a lot of risks. So I put this table in. This is from the CDC. You can, if you want to add this to your policy, the link is at the bottom. So different animals are able to have different diseases. As you can see, cats are not the health. I mean, they have a lot of diseases they are able to carry that a lot of them can be transferred to humans. So keep that in mind when you're looking at what kind of animals you want to bring into your facilities. As I'm sure a lot of you know, at petting zoos and things like that, a lot of the chicks can have salmonella and cause salmonella outbreaks. Reptiles can cause outbreaks. There have been a couple of papers that have shown that therapy dogs, when they go into hospitals and they're interacting with patients, when they test the dog's paws and stuff before they go in, they don't have anything. And then when they test the fur and the paws after they go in, they can have C. diff or MRSA on their paws and fur. So you definitely can have at least I don't know if you'd call it colonization, but they can have those organisms on their paws and fur, and in theory, that could be transported or transferred to someone else. So that's another reason it's really important to have the dog be freshly bathed. And then I have some other strategies on a future slide about other things you can do to help prevent the spread of these organisms, which is here. So it's really important that residents and staff perform hand hygiene after handling animals. That is the number one thing I would say that really can help stop the spread of any of this. Because if there's fecal matter or something on one of the animals, and then the residents go and eat or touch their mouth, then hello, salmonella. So if they're cleaning their hands after handling the animals, that will get rid of a lot of the pathogens that they might have on their hands. It's really, I hope you guys would all do this anyways, but residents should never have contact with animal urine and feces. If an accident does occur, make sure your staff who are cleaning it up or the handler who's cleaning it up wears gloves. And then if you're expecting splashes or sprays, like if the dog is puking or something, wear a gown and maybe facial protection then, and discard all the soiled materials into a leak-proof bag, and make sure you're doing proper cleaning and disinfection where it occurred. So I think a lot of you know the principles of cleaning and disinfection, but you actually have to remove the physical matter first before you can do, and like clean the surface before you should do disinfectant. There are some cleaner disinfectant like joint products, but you can't just like wipe a wipe over some poop and then everything's clean. That's not really how it works. If you do have a resident with open wounds or devices, please don't allow that animal to come into contact with those wounds and devices. It's the same idea around like EPP and things like that. You want to make sure those wounds and devices are protected from the introduction of organisms. If you have, let's say, a bedbound resident or even a visitor bringing a pet, and they're in the resident's room and they're going to be on the bed, put down a towel or put down a sheet and have the dog or whatever animal, the bunny, sit on that sheet so that, or on the towel, so that they're not coming into direct contact with those residents' linens. Oh, I see. Thanks for the hand sanitizers. Great. Oh, I'm really excited to see that it increased the rate of hand hygiene. So I'm going to do a quick aside. For those of you who weren't on the last roundtable, we presented the findings from that focus groups, or those 2 focus groups we did, and the main finding that we had was that CNAs felt that they would increase their hand hygiene compliance if they actually had access to pocket hand sanitizer. So we delivered, I think all the SNFs already got them, 8 cases of, I think, 24 bottles to each of you for free. And please hand those out to your clinical staff. But also make sure there's hand sanitizer available. I should have added this to the slide to, if you're doing, pet therapy or you're having a dog come to the activity room, make sure there's hand sanitizer available in the activity room and make sure the staff are doing facilitating hand hygiene for all the residents when they're leaving that room. And then the other thing is if an animal bite or scratch occurs, which can happen, definitely clean the wound, provide first aid, assess if they need additional medical evaluation, and complete your incident report. Cats, again, as I showed in the previous slide, can like carry a lot of things. So if it's a cat bite, that can make it a little more urgent that they get medical treatment. If it's not a service, well, even if it's a service dog, but if it's like an animal again that you're like, oh, on Tuesdays we bring in this dog and everyone pets them and the dog starts biting people, you can be like, no, we're not using that dog anymore. So that would not be considered a service animal. So if it was like, oh, a resident like really was roughhousing and the dog scratched them or a cat accidentally scratched them, you should assess whether you want to keep them in the program. But if it's like an actual bite or the animal seems aggressive, then kick them out. And then make sure you continue to monitor the individual who's bitten or scratched because you might not have an infection at the beginning, but then a couple days later you have an infection. Oh, thanks, Francis. Yeah, I thought it was interesting too. I think that might be my last. Nope, it's not. Okay, so I stole this slide verbatim. I was going to try to rewrite it, but I didn't even see the point. So this is from that presentation I watched that inspired this presentation. Again, these slides will be sent to you. They're going to be on the website, but this has what you should put in your pet policy and do this. And then you can also look at the slides I had previously, with the CDC table of what pets can have what organisms. But if you don't have a pet policy in place, please put this in place. Again, like write down what a service animal would be, what questions the staff would be allowed to ask about the service animal. Make sure everyone understands the stipulations around that, and then make sure you have a process in place if you have therapy animals, what records you want to have, what you do in the event there was a bite, and things like that. So this is suggestions. If you don't already have a pet policy, write one. And if you do already have a pet policy, read this slide and make sure everything in there is in your policy. Okay. Javante's really into this mini horse. We'll talk after. Did I miss any questions? Maria, I still see your hand up. Do you have anything you want to ask? Or if you want to throw it in the chat if your mic's not working? No? Okay, so I will pass it. Oh, is there someone else? Let me see. I see another hand. Lauren, what's up?
Yeah, hi. Unfortunately, I can't text in the chat for some reason.
Oh, weird.
When you're done with this presentation, I have a COVID question. So whenever you're ready.
Yeah.
Oh, okay. So I had somebody at our company had reached out to Hillary.
Yeah.
Because the CDC COVID tracker is no longer available. And so it doesn't contain the county level anymore, which then drives when to consider, implementing for certain type of things.
Mm-hmm.
And her response was that they're working on new COVID guidelines and to follow the respiratory virus activity levels. Have you guys heard of anything or, like what I'm mentioning, that anything's changed?
No, so I do think it is frustrating that CDC has not updated their healthcare guidance yet because they basically took away all the metrics you would need to look at in order to determine what you should do and then replaced it with this other thing. I mean, I was CC'd on that email as well. So yes, I'm not sure exactly what they are looking for you to do in the absence of these other metrics, but I think generally what you would do is like, hey, if there's like right now, there's not any flu. So And the flu vaccine that was created was for last season. So you don't have to do like a ton of surveillance for flu at this very moment. If someone has respiratory illness, like, and they're not COVID positive, then they most likely don't have flu, although it's always still a good idea to do a respiratory viral panel. So in that regard, like you can look at the respiratory illness activity, see that there's not really flu and not really worry specifically about flu at this moment. But if you start seeing increases in respiratory illness activity, let's say RSV or COVID, then you can kind of amend, maybe you want to put universal masking back in place. But it's kind of a nebulous situation right now because before it was like, hey, if it's high levels of this, then you need to test all new admissions. And that's not really, it does still have
Right.
that in there. But so I guess, yeah, if that's what you're looking for, an equivalent of like when do we start testing new admissions, it's kind of
Yeah.
up to you at that point. It's not, I don't think you would get cited. And if anyone from, I think I might have seen Karen or Tracy's on as well. But I don't think a surveyor is going to come in and say, hey, we're citing you because you're not testing new admissions because you don't have a clear metric by which you would use that. Tracy, do you have any feedback on that? Tracy's from IDPH.
No, we have gotten a lot of questions very, very similar to that, and people wanting very, very specific answers, and we just don't have it at this time. This summer is going to be kind of a little bit preparing for next flu season, next respiratory season, and I would just expect, keep an eye out that something will be coming out.
Yeah, and to IDPH's credit, CDC has not made any updates. And generally, what happens is CDC makes guidance, IDPH follows that guidance and kind of operationalizes it for the state. And then we follow IDPH's guidance. Sometimes we have minor changes, like back when COVID was really a problem. We had like usually the state had that red, yellow, green zone for COVID, and we made a blue and gray zone. So like sometimes we have slight variations, but generally speaking, we're the federal, state, and local guidance is all in alignment. It's just the federal guidance hasn't changed yet. But IDPH and CDPH are cognizant of the fact that things are different now. So we're trying to do the best that we can. But hopefully the federal guidance changes soon. But like as Tracy said, and Dr. Spencer said, they are working on updating their guidance. Any other questions? Or did that answer your question, Lauren? Kind of.
Well, you concurred with it, but still
Yeah.
no answers.
Yeah.
But thank you for trying.
No worries. Yeah, I don't know. Yes, but I acknowledge that they're asking you that the guidance says to look at a metric that no longer exists. Okay, so I am going to pass it over to Barb, who's going to present on some infection control safety topics. And then while she's presenting, I'm going to try to find that website I found with the organizations that provide that pet therapy. But big disclaimer that if I find it and put it in the chat, I'm not endorsing it. I've never worked with any of these companies. I'm just trying to get you guys some resources. So this is not necessarily a CDPH endorsed company. Okay, take it away, Barb.
Good afternoon, all. My name is Barbara Brown. I am an infection prevention specialist at CDPH on the healthcare setting team. Today, we're going to talk a little bit about the importance of resident safety in infection prevention and control. The importance of resident safety in infection prevention and control is to prevent cross-contamination of pathogens being passed from one person to another. Good infection prevention and control practices are important to help reduce infections in the workplace and improve resident outcomes. Next slide, please. So, conducting regular audits of hand hygiene, environmental cleaning, and providing continued education to staff are important infection prevention and control strategies. Next slide. So, what does a safe and effective infection prevention and control program look like? So, healthcare facilities should have a process in place to ensure that all healthcare personnel understand and are competent to adherence to infection prevention and control procedures as they perform their roles and responsibilities. For example, making sure that high-touch surfaces inside and outside of the residence environment are cleaned and disinfected with recommended solutions. Try using secret shoppers for direct observations of healthcare personnel adherence to specific job duties. Implement the appropriate isolation for residents' suspected diagnosis. Making sure the overuse of antibiotics is not being used. Provide competency training for staff in response to non-adherence or lapses in infection prevention and control practices. Next slide, please. Why good infection prevention and control practices are everyone's responsibility. Compliance with infection prevention and control practices prevent the spread of infections within healthcare facilities, and non-compliance with these measures poses a significant risk to everyone. So it is all of our responsibility to practice good infection prevention and control practices to help prevent the spread of infections within these healthcare facilities. Next slide, please. Best practices and strategies for maintaining infection prevention and control in healthcare facilities. We have a list right here. These are very good infection prevention practices and strategies. And without these infection prevention and control strategies, it is impossible to maintain safe and quality healthcare services in a healthcare setting. So the whole goal is to interrupt the chain of transmission. Next slide, please. How does infection prevention and control fit into a safety program? You want to knock those pathogens out like that guy is doing with that boxing glove. So I want you to ask yourself 3 questions. What does your infection prevention and control safety program look like? Do you have the necessary resources to promote safety in infection prevention and control in your healthcare facility? Lastly, are you taking the appropriate actions needed to keep your residents safe? If you can answer all 3 of those questions with a yes, you're doing a great and awesome job. Thank you.
Okay, great. Thanks, Barb. I found some resources about animal-assisted therapy places in Chicago. So the first link I put in there is a random company I found. Again, not endorsing them, but there is an adorable dog named Pop-Tart. So if you use them, please get Pop-Tart and send me a picture. But then I found a list from Shirley Ryan. So go to that list. That's better. That has a bunch of different options of places endorsed by Shirley Ryan. And then, oh, it has a horse section. So Javante, monkeys, would not recommend bringing a monkey in. Anyways, sorry, I'm digressing. But that last link I put in the chat
Oh
has
no, my
okay.
face torn off.
um no, I'm talking about the horses you can look for. But anyways,
Oh,
that
you said
has
something about monkeys.
yeah,
I was
I
like,
was saying
no,
horse. I was
absolutely not.
scrolling. I
No.
saw horses and then I'm scrolling and saw monkeys. But anyways, they have the addresses, the phone numbers. Oh my God, I thought I saw hippo. No, hippo therapy. Oh no, that says horses. Okay.
Yes, no.
You can invite me if there's hippos in your place. But anyways, look at that listing. There was a question about, Mark says the Lincoln Park Zoo is free. Oh my God, if you guys took your residents on a field trip to Lincoln Park Zoo, tell me, I'll come hang out with you. And then there was a question about sharing the slides. So we do post these slides on our website afterwards. And then if you work at a facility, like one of the SNFs within Chicago's jurisdiction, we send them out every time we do a follow-up call. And did I miss any questions? I don't think so. Okay, any other questions for me before we end? No, and then just a heads up that I will be out of town next for the next roundtable. So Stephanie V is taking over. So all of you better be nice to her, and when she asks questions, you better answer them and don't make me be disappointed. And then Tom is gonna present on Elizabeth Kingia and Legionella and other waterborne pathogens. So definitely encourage you to come to that as well. But hope everyone has a great rest of your month. Oh, one other thing. So I've already booked a speaker for August who's going to come on and talk about cost savings associated with enhanced barrier precautions. So that would be another one to come to, especially if you're corporate and you need that justification. So thank you, everyone, and have a good rest of your month.